Hello, everyone, and welcome to a presentation concerning promoting collaboration and managing risks in healthcare transitions. My name is Karen Davila. I am board certified in healthcare law, and I practice here at the Florida Healthcare Law Firm in Delray Beach, Florida. Thank you again for joining. And since this is not an interactive presentation, it's audio only, I invite you to reach out to me if at the end of the presentation you find that you have questions. My contact information is included on the last slide. And I hope through this presentation you find some information that will be useful to you as you go about your day-to-day work. So what we'll be talking about really are care transitions and how important communication among all healthcare providers at all stages of care is critical to the health and safety of patients. In order to really drill down on that, we need to be mindful of where care transitions occur and maybe open up our eyes to the fact that care transitions occur more frequently than our traditional notions of where care transitions occur. We'll talk about how to assure an effective care transition, promoting health and safety for our patients. We'll also talk about the correlation between communication, documentation, and the accuracy of that, and medical error. We'll discuss the limitations of documentation by itself and implications of poor communication and how those affect liability for healthcare providers. What we'll cover includes a fairly well-rounded description or definition of care transitions. We'll talk about good documentation. Some of this may sound foundational, but I think it's important from my perspective to lay the foundation for these things so that when you're talking about where the opportunities exist, you start to recognize those challenges. We'll also talk about EMR and whether that's better or worse, whether it helps in a care transition or could be problematic. We'll also talk about charting by exception and whether that is good or problematic in care transitions. We'll talk about the nature of communication and documentation at the point of care transition and challenges and or barriers that healthcare providers face at the point of care transitions. We'll talk a little bit about the role of documentation in a medical malpractice case, and probably a big aspect of this presentation, and again, this goes to the purpose of this conversation at this point, is some lessons we learned during the pandemic. And so I'll spend some time talking about some things that happened that were unique to the pandemic and what we learned from that and where there were opportunities. We'll then go into my list. And again, this is just my thoughts on the top 10 takeaways, some lessons I learned and felt like would be useful to carry forward, having gone through the last roughly 18 months. And then, although in the live session, there will be opportunity for Q&A, again, I invite you to contact me via email if you do have any questions about the materials being presented. So let's talk about when a care transition occurs. So our traditional notion of care transitions certainly cover going from a hospital to a skilled nursing facility, from a skilled nursing facility to a hospital. What about from outside the hospital to the ED? Is that a care transition? What about from the ED up to the floors? What about PACU to one of the floors? These are all things where we have to be thinking, is a care transition occurring? And the reason we need to identify care transitions and know when a care transition is occurring is because those are the points of risk for breakdown in communication and documentation that can lead to medical errors and health and safety risks for our patients. So we need to be inclusive in the concept of care transition. We need to include transfers within the hospital. We need to include shift change. So the patient never changes beds, but the staff caring for the patient changes. And so anytime you have a change in the personnel providing care for a patient is a transition in care, and it's important that communication is effective and complete at that point. And then also we need to be thinking about when a patient is discharged to home, that is also a care transition, because there are going to be caregivers, whether it's the patient or family members, who are going to help that patient transition to a home environment safely. And so communication at that point, again, is very critical. We've all heard this language and we all understand, I guess, the basic principles of that. And in particular, at the point of discharge to home, we all know that discharge instructions are issued. But if we really think about how discharges occur, sometimes we'll recognize that those discharges and the communications to patients and their family or loved ones may not be as effective as we think. In fact, recent experience of my own, leaving an emergency department after having had an emergent visit, I received very poor directions on discharge. I was handed papers, and the papers had what I would call standard instructions for certain types of injuries. But there really was very little conversation about that. There was very little conversation about any follow-up if I should need it and so forth. And that is not unique to me. I have seen this happen time and again. And so again, we do believe that good communication is occurring when patients are being discharged home, but there's opportunity in each of these care transitions, including there. So essentially, we need to be thinking about a care transition that occurs when all or a part of a patient's care is transferred from one caregiver to another, whether it involves a change of location or not. So it's helpful also to think about what makes for good documentation and the importance of these various elements in terms of the care transition. So when we talk about what is good documentation, certainly accurate, relevant, and consistent. This goes to shift, whether the documentation consistently demonstrates the patient's status or not, whether it's accurate. I have a case study later in the presentation that you will be able to see an example where this problem arises. The information should be clear and concise, because what you document is going to be read and interpreted by somebody else. And so if it is not clear, there's the chance for misinterpretation, misapplication of some principle, and then doing something that may not be in the best interest of the patient. It has to be complete and legible, and it needs to be done contemporaneous with the events occurring. Also helpful if it is sequential. And although I know late entries are permissible if they're properly dated and signed, dated, timed, and signed, they can be a challenge, particularly if they're done after other care is rendered, because the other care that's rendered is going to be rendered without the knowledge of that activity that occurred that was documented late. So again, very critical that documentation be timely, contemporaneous, and sequential. In addition, it has to be available. It has to be available to the caregivers at the time of transition, because that's the moment when they need to know what to do. That's the moment that they're going to be relying on that documentation. And so the absence of documentation at the point of care transition can be problematic, again, for the health and safety of patients. So number one reason we document is, of course, the safety of the patient and the quality of the care rendered to our patients. But it also is done to assure that care is continued across the entire episode of a patient's illness, hospitalization, or medical care. So it allows for that continuity when the patient moves from one place to another, changes, team members providing care for that patient. Every time a care transition occurs, that continuity needs to exist. So if skin care is being provided to prevent skin breakdown, that skin care should continue unless there's a documented reason why it didn't continue. It shouldn't abruptly stop and wait until the oncoming care provider learns from the charts that there was skin intervention previously that wasn't carried forward. It also is a written record of the communication between and among caregivers. And when I speak to that, when I speak to communication, it is both a written record unto itself of the care provided, but it's also a record of verbal communications that occur at the time of a care transition. It is a record of communication between the patients and the caregivers as well. So when you give discharge instructions, or when you're providing instructions to patients about fall safety and the instructions that they're to remain in bed and use call lights and so forth, documenting that you've done that is important to demonstrate the constant communication between the caregivers and patients. Additionally, it's a record of a patient's condition and changes in that condition. Absent a record of the condition and changes in the condition, it would be difficult for an oncoming care provider to know and understand where they are supposed to jump in and how they can best assist the patient. So patient's condition and changes in patient's condition should be routinely evaluated and documented. It is also for reimbursement and evidence in medical malpractice cases. We won't focus on reimbursement as a reason for documentation in this presentation, but clearly that becomes important when a payer is determining what level of care to pay or how much to pay. So let's take a look at the first case study. Here we've got really, we're challenging you to answer whether you can remember something 2 years after it happened. So put yourself in the shoes of these care providers. So patient's admitted for a surgical procedure, alert, oriented, and capable of self-care. He goes from the operating room to PACU to a med-surg unit. Sounds like a normal course, and later discharged to SNF for additional rehab. He was then discharged home and returned to the ER where he coded and died. Here, the case is brought 2 years later, where you're asked to give a deposition, and each of the care providers have to recall the details of the care rendered. We all know what they're going to rely upon. Very few of these care providers will remember the patient, the circumstances, or what was done. The only point of reference they have is the documentation they created at that time. And that is a very important reason why the documentation is important. So in addition to just simply being important, how we document is important. And these are just some examples that, while they may seem a bit silly when you see what was documented versus what should have been documented. And again, these are real examples taken from charts over years, but the examples demonstrate that the subjective statements written by nurses, like appears confused or taking oral fluids well, may not be adequate to communicate to the oncoming care providers. And so appears confused, an oncoming care provider might not understand how they came to that conclusion. But if instead the statement is patient found in lobby, stated he thought he was at the airport, it should be more obvious to the oncoming care providers what the current situation is and how they can best assist the patient. Other examples here, taking oral fluids well, the fifth one down, 1,000, it says, taking oral fluids well, 1,000. Instead, the suggested language might be drank 1,000 mLs, so we know that 1,000 is mLs, since 0700, so we know the period of time over which they drank that, and it is less subjective, it's factual. The nervous, the example of the nervous, patient asked several times about length of hospitalization, expected discomfort, and time off work. Again, this is just an example where if you document that the patient was nervous, it's unclear what they're nervous about. Here, this is not really that they're nervous, they're just concerned and maybe need additional information, and so communication might be important there to assuage any concerns the patient has. So when you talk about EMR, is it better or worse in the context of specifically care transitions? So some research suggests that an EMR could certainly improve efficiency of care, care coordination, and patient safety. And when you see care coordination, I'm thinking, and I'm looking at this from the standpoint of care transitions. Care coordination occurs during care transitions and the communications between the care providers. So here the question would be, is it more efficient and does it improve care coordination? Some research says so. Other findings suggest that use of EMRs may decrease the rate of things falling through the cracks. EMRs are also associated with more frequent medication errors, poor quality of care, and poor confidence in patients' readiness for discharge. So let's break that down a bit. Frequent medication errors. It would seem that that would be a surprising result for more medication errors, but it could be that it's just that when medication is charted, might not be contemporaneous with, or when medications are discharged, those are not being recorded in the EMR. But poor quality of care, certainly we can talk about further, and we'll do so on the next slide. So some of the questions about the poor care or quality, at least as it is reflected in the EMR, relate to some of the challenges of EMRs. And so one of them is that an EMR forces choices. So while you might not have the best language when you're told to select from a drop-down option and the only options are A, B, or C, and you would prefer D, other, and then they'd like to put narrative in there, when that's not available, you're forced through some choices. And then, of course, those limitations of the drop-down options kind of trigger the video game mentality. And I talk about that and certainly could talk about that in a number of contexts. But one of the examples is if you fill out the same form repeatedly and you know what option you're going to pick, you form habits, muscle memory, and so you click through very quickly and enter certain information. And in some cases that can get you in trouble. An example I had recently was a skilled nursing case where a patient was transferred from a hospital with skin intervention in place to prevent skin breakdown. And upon transfer to the skilled nursing facility, they did not implement the interventions, and the patient had a very rapid skin breakdown. And when we went to look back at the electronic medical record generated report, when it got to the portion on skin breakdown, it said NA. Obviously, this was an option to select for patients who didn't have a skin integrity issue, but here NA was the wrong choice and may have arisen. And again, this is my speculation, but I think it's reasonable to assume it occurred because the nurse charting went quickly through all of the standard things that they had to do, and the video game mentality forced them through a series of prompts to get there. Workarounds is another example that occurs in the context of the EMR, because the EMR doesn't always do what we want it to do. And so when we find that the EMR wasn't built to contemplate certain circumstances, we create workflow around the EMR, and that can create issues for the accuracy of the documentation, where the documentation resides. In other words, if the workaround is created such that documentation of certain skin integrity interventions exists in a place other than where it should exist, that can be a problem for other caregivers to find. So, I'm sure you can think of other challenges that the EMR presents to our care providers, and we need to be thinking about whether there are ways to reduce that friction with EMR and the desire to provide high quality, and safe care and good communication between care providers. So what about charting by exception? Is charting by exception good or bad for care transitions? Well, in a Charting by exception environment, at a minimum, you have to chart a comprehensive initial assessment to establish the baseline patient condition. You do periodic reassessment of the patient's condition and are supposed to document any changes in condition. Verbal orders and oral communications are supposed to be captured, and all treatment provided must be captured, including fall interventions, skin breakdown interventions, and medications administered or withheld, and also any changes in medications or cancellations of medications. So what's the problem? Well, in general, if something is not documented, we've all heard the old adage that if it isn't documented, it didn't happen. So is charting by exception effective? Well, in a care transition, charting by exception may leave a lot to be desired, particularly where the patient's current condition has not been properly updated, recognized, changes recognized, and care planning done around that. So, charting by exception should have well-defined guidelines and standards of care, but the biggest challenge is the consistency of execution by care providers, particularly where they're not accustomed to charting by exception. And you'll see on this slide that I have the chain link, and I point out that is there because really a common theme across this care transitions presentation is the theme of the weakest link. Wherever that weakest link is, and care transitions can be weak links, right? Places where there is higher risk. We need to be very careful to build stronger links for that care transition. So let's look at the second case study. The second case study talks about a nurse who on the previous shift documented that the central line dressing had blood visible through the dressing. Seems appropriate to have done that. She then went on to change the dressing, but neglected to change the status of the dressing to clean, dry, and intact. Another nurse comes on next shift and carries forward the documentation, which said that the dressing had blood visible through the dressing, that it was unsoiled or soiled and unchanged. Because the policy requires that the dressing be changed every 7 days or when soiled, loose, or signs of visible blood, the absence or the carry forward of that documentation that it wasn't changed demonstrates that care was not provided that we as an organization who wrote that policy agreed was required. So does that happen in an EMR situation? Absolutely. We've talked about how that happens. It happens a lot easier because people want to carry forward information so they don't have to re-enter information. And so it's much easier to carry it forward. And if that were the last portion of a note that was a lengthy note and everything else was accurate, carrying that forward would be a fairly easy mistake to do as a cut and paste. Can it happen in a charting by exception situation? You would expect that it wouldn't, because this is clearly an exception that requires a change. And so it is a recognition that there's a change in condition, that you're taking action, intervening to change the dressing. And yet, even in a charting by exception situation, it can happen because the staff are accustomed to, and if they're not well trained to recognize what should be charted and what shouldn't, it's something that could get missed. So here, even though the nurse complied with the dressing change policy, the documentation didn't evidence that the care was actually rendered. And that will create a problem later if anybody should challenge what happened, particularly if the central line becomes infected or there are other problems at that site. So let's talk about effective communication at a point of care transition. First of all, we should recognize it's essential to assure safe and timely patient care. When a patient is transitioned from a hospital to a skilled nursing needs to know immediately at the time the patient is received that there are certain things that have to be carried forward, and be done, particularly where there's wound care involved or fall safety issues. Without knowing that immediately, time might lapse before they complete the initial assessment and implement the care that is required. All information transferred has to be up to date, accurate, and reflect the patient's needs and preferences. Again, where medications were administered just before transfer, if the administration of the medication was not documented, that will create a problem for the oncoming caregiver, who might administer another dose and duplicate the medication in error. So again, these are very important things to make sure are up to date and accurate. Similarly, a discontinuation of a medication or a change in the patient's condition immediately prior to a care transition, because the care provider receiving the patient may have looked at the document a while before and not be prepared or recognize that a change in the condition occurred. So that's all very important. So it's really not just documentation, but it's also the communication that happens when the patient transitions from one care provider to another. And that has a significant impact on the quality and safety of the care rendered immediately post-transition. So during care transitions, studies have shown there's an increased risk of communication errors, particularly because people who are transitioning care or giving shift report, for example, they are busy moving on to the next thing. Sometimes time is short, and when we've had staffing shortages, that becomes more acute because we realize that shift change, for example, is reduced further and further, and more patients more patient load is given to each nurse. Excuse me. Communication errors often contribute to sentinel events as well. And so for all of these reasons, being very thoughtful about the communications that occur at the point of care transition is critical. Nationally, about 18% of all patients discharged from hospitals to nursing homes are readmitted within 30 days. Let's talk about that. We've been working on reducing the readmit to hospital from SNF after discharge. We've been working on that for some time. And yet we still have 18% being discharged back to hospitals. Could we speculate that some of that is because the adequate communication about the level of care the patient needed was not communicated, that if properly assessed by the nursing home, they could evaluate whether they would be able to deliver the care better, such that fewer patients would be readmitted? It's possible that that is a contributing factor, that the care transitions that are occurring and the communications at the time of care transition are not adequate. So what are the biggest challenges when transferring a patient, for example, from a hospital to a nursing home and vice versa? I mean, we can talk about how you can provide an entire EMR, and that would not be sufficient to prepare the nursing home to receive that patient, because it would require the nursing home staff to review the chart, determine what was critical, and prepare for that, all simultaneous with receiving the patient. So there are some challenges there. Similarly, coming back from the nursing home to the hospital, similar issues of the ability to fully understand and appreciate the patient's condition and immediate medical needs. So some of the barriers to transitions of care include, the timely ability to deliver medication information, infection prevention challenges. And we saw a lot of that during the COVID-19 pandemic and continue to see it, although the situation has improved substantially with rapid testing, more accurate testing, and changes in how we approach the disease in general. Fall risks are important to know about, and skin breakdown. But there are others, of course, and every patient will have his or her own unique concerns that will be challenges at the point of any care transition unless they're properly communicated. So how can we improve care transition communication? What are some of the things that organizations are doing best practice wise? So one of the things many organizations have done, in fact, it's best practice, is to develop standardized handoff forms. And of course, those handoff forms will have key or critical information. And then the question is, when and how is that information shared? Because if this handoff form is shared too long before the patient is transferred or care is transitioned, the information may become outdated, again, related to changes in condition, medication administration, a fall that occurs immediately before transfer, and so forth. How that information is shared is critical, because simply giving somebody a standardized handoff form will not be adequate to thoroughly bring the unique aspects of that particular patient to the caregiver's attention. So really encourage early and frequent communication with post-discharge care providers about patients that are being transferred, discussions about what information they need. And if you work with some of the same ones frequently, developing a standardized approach to care transitions between and among the key stakeholders would be very beneficial. And we've seen that approach take effect in several places, including outreach to key stakeholders, collaboration as to key elements, and then periodic evaluation and adjustment as you learn about the challenges that you've experienced over the more recent transfers. So when you're transferring, stop and think, what would be the most important things the next caregiver would want to know about a patient? What are those things that will help the next caregiver assure safe healthcare for that patient? And how will you communicate that information? Given that you've thought about what those things are and how you'll communicate it, does the chart either electronic medical record or other documentation support that? Is it consistent with that? Is there anything that is missing from the chart documentation that you think is important because you've now sat down and thought about that, right? And the other thing is, and I pointed this out before, with EMRs, sometimes there's not a right place to record information. So identifying where information was that was important and was recorded should be identified and pointed out to the receiving caregiver. So let's take a look at another case study. Here, a patient was transferred to a SNF 3 days post-op, and 2 days post-discharge has a fractured femur due to a fall, transferred back to the hospital, and she died 16 days later. I know most of my cases end in death. That is not necessarily true in real life, but it brings home how important some of these things are. So in any event, during the initial hospital SNF transfer, a copy of the EMR was provided, and it included well-documented post-op status with high risk of falls and what they were doing to prevent those falls, the protocols, right? Then a provider-to-provider discussion was held, and key patient concerns, including falls, was held, but neither the receiving provider nor the transferring provider documented the provider-to-provider discussion. At the SNF, when the patient arrived, the admission documentation indicated low risk for falls, and no specific fall risk protocols were implemented. So what do you think happened there? Could it be that the provider-to-provider discussion happened between one set of people, and that the caregiver who first had to evaluate the patient and implement any protocols was a different person? That certainly would be a breakdown in communication. But in any event, there is a breakdown there. Clearly, somebody did not communicate the information that was needed to the or within the skilled nursing facility, such that the fall risk protocols would have been implemented. So what do you think the outcome of litigation in a case like this would be? Well, assuming there were people testifying or in a deposition stated that from the hospital that here's our documentation, it clearly said fall prevention protocols were in place. And I specifically remember speaking to provider X, the caregiver who received the transition information. I specifically recall speaking with that person and told them about the fall risk, among other things. At the SNF, and if they are testified to that, it's possible that they will not have an issue. However, the SNF clearly will have an issue because the documentation they received from the hospital shows that fall risk protocols were implemented. They can certainly say that the hospital never communicated that verbally to them, but they would be hard pressed to argue that because they also did not document that provider to provider communication at the point of transfer. So really, this goes to documenting critical discussions and the importance of that. So talking briefly about documentation in the medical malpractice case, and I talk about this because, again, knowing what the impact of good documentation or poor documentation is on a medical malpractice case makes us want to take opportunities to improve whatever that documentation is and the communication around that documentation. We know that in a malpractice case, documentation is a 20/20 hindsight thing, meaning the gaps become very obvious. Any gaps in documentation become very obvious, almost an aha, and you realize, shoot, you wish you had charted that, okay? And, then you've got to think, so what percentage of malpractice cases are won lost on documentation alone? Well, I doubt that many are won lost on documentation alone, but I can tell you this, and when I'm talking about won lost, I don't mean just in trial. I do mean where a provider is forced to settle or feels like the best option is to settle because of the risk of trying a case where documentation is missing. So a lot of cases are decided whether to settle or not, whether to try or not, on the basis of whether the documentation is good. In one case, I had one case alone. I've had outside counsel or our defense counsel say that was A+ documentation, and I would be proud to take this case to trial if we should need to. Most other cases, I hear things like, I wish I had better documentation. The nurses are very well spoken. They tell us about the good care they rendered, but the documentation doesn't reflect that. So that becomes a problem. And really, can we rely upon our memory? What a particular patient, what happened, how, who was present? So in the rearview mirror, documentation is going to be viewed in a light most favorable to the patient and to the plaintiff. If something is missing, it's going to reflect poorly on the provider and force difficult discussions about whether to settle cases or not. So then you think, why do patients or families sue healthcare providers? Oftentimes, and again, this is documented, oftentimes lawsuits are generated because of poor communication with patients and families. And in the case of COVID, we'll talk a little bit about that and how that some of what happened in the pandemic might have created additional problems because of the inability for the family members to speak with the patients in instances where the patients were in quarantine. And so what could be done to minimize the likelihood of a claim? I would suggest that good communication, better communication with the caregivers and with the patients and family would mitigate or minimize the likelihood of a lawsuit, even where there's a negative outcome. So the top issues in malpractice cases should not be a surprise: absence of documentation, timing of documentation, meaning late entries, and failure to record certain things, including care transition communications. So when we're looking at the malpractice case, what you want to be thinking about is whether the documentation will support claims that the care provider conducted and recorded that comprehensive initial assessment and periodic assessments thereafter, that the care providers formulated, individualized, and followed plans of care for the patient, that they observed, monitored, and performed treatments according to accepted standards, and that they charted patients' response to any interventions, initiated a response to changes in conditions. So recognize changes in condition, and then implement interventions as appropriate, and then communicating between and among care providers at the points of care transition. If those are not evident from the documentation, the case may be difficult to defend. So let's talk about during the pandemic. During the pandemic, it was a national emergency, and one of the things that happened was CMS issued multiple Section 1135 waivers due to the national emergency. What are those? The Section 1135 waivers are blanket waivers for healthcare providers, telling them that they didn't have to comply with some of the standards that allow providers to get paid by Medicare. So these are conditions under which the healthcare providers normally operate, but those conditions were lifted or waived during the period of the pandemic. And it's interesting to note that there were a lot of them. It wasn't just one or two, but there were a lot. And in each case, I wonder, and I suspect we'll learn over time, that some of those waivers contributed in part to some of the breakdown in communication and care rendered. Some of the examples, and again, you can find this document, by the way, it's published, it's called COVID-19 Emergency Declaration Blanket Waivers for Healthcare Providers. And it was updated May 24, 2021. So most, the ones I'm going to talk about are still waivers that are in place right now. So examples that I think implicate care transitions and our ability to deliver safe care during care transitions and immediately following included things like verbal orders could be received, but they didn't have to be authenticated until 48 hours later. If a care transition occurred during that time and something bad happened, a physician might suggest that the order was not properly recorded in the chart, or it might not properly reflect the patient's condition at the time that it's recorded. So that can be a problem. Some patient rights were waived. In other words, we were required in many healthcare settings to prevent visitation, to prevent the spread of COVID-19. Well, with fewer caregivers, with fewer loved ones, family members interacting with patients, they were not able to advocate, observe, and take steps to assure safe healthcare was being provided to their loved one. And we all know that families have often been part of the care team when a patient is in a hospital. And so the absence of those people at the bedside created some challenges to care transition. Additional information or additional waiver included the requirement for detailed information or limiting the detailed discharge planning for hospitals. And so this particular waiver, CMS waived all requirements related to post-acute care services so as to expedite the safe discharge and movement of patients among care settings and to be responsive to fluid situations in various areas of the country. And although CMS maintained the discharge planning requirements that ensure a patient is discharged to an appropriate setting with necessary medical information and goals of care, as set forth in 42 CFR, the appropriate sections, one would question whether the waiver of more detailed discharge planning might have contributed to lack of adequate communication at the point of transition. So I simply call that out and challenge that. I won't go through all of these waivers, but it is important to note that they exist also for the caliber of staff or the credentialing of the staff. So you had new people entering the hospitals and skilled nursing, they were contractors. They were people who weren't fully credentialed because the credentialing was waived for new physicians so that they could practice. And some of the requirements for level of care, whether it was provided by a physician or other allied health professionals, that was also waived. And so different people or professionals were providing care that they might not normally provide. And all of those things can contribute to challenges with the care transitions. The nursing services, the requirement to develop and keep a nursing care plan for each patient and requiring the hospital to have policies and procedures in place. That was waived as well. So again, I call out these waivers because at the top of this, this is the lessons learned. I think you can see where breakdowns might have occurred that would have caused challenges in care transitions. So let's talk about some of those lessons. Really, it should be clear that effective and consistent processes are critical for communicating at any point in care transition. And when we attempt to change or shortcut the processes, we can create communication voids, and those communication voids can put patients at risk. We had shortage of resources. That certainly led to some of those shortcuts and reduced communication. We didn't have enough beds, we didn't have enough staff. And so what we found was people were trying to create a workflow outside the normal workflow, and there were some failures with that. One of the things that you might recall from early on in the pandemic is that labs were significantly delayed. And so there was a requirement to put people in quarantine until we knew whether they were just a person of interest, person under investigation, or whether they were COVID positive or released. And so we had more people in quarantine that maybe needed to be, but the quarantine protocols were even more critical at that time because of the inability to get reliable COVID testing. In fact, in many instances, we had testing that wasn't accurate. We had a lot of positives that later weren't, and we had a lot of negatives that really should have been positives. And all of those are important. So the other thing that I learned from working on some investigations and some other things that I did during the pandemic were that universal precautions were not being routinely followed, even in the most risky places where COVID positive patients were being held. Although universal precautions have been the standard of care for decades, they are not consistently followed. If any of you have gone to a lab to have blood drawn and you see the person pull the fingertip off of the glove to palpate your arm to locate the vein, that's a perfect example. And if you confront them about that or ask them very politely why they do that, they say they can do their job better, but they can't do their job if they get sick. And so I struggle with whether or if they cause somebody else to be sick, that can be a problem. So it's interesting. That's just a real simple example. But in the case of COVID, there was training needed to teach people how to use PPE, don and doff, and the training was not sufficient. And there was confusion among the team members about whether to change their PPE before going into different rooms. And that left plenty of opportunities and created some risk for cross-contamination. And then last is just a bit of a tongue-in-cheek. It's easy to manage the obvious, right? Here, COVID was a bit silent. Not everybody had symptoms. Not everybody was able to, not everybody demonstrated obvious signs of the disease. And so where it wasn't obvious, it was hard to manage. And we struggled with that for quite a while because there were a lot of people who were getting sick, carrying it, and weren't aware. So as you remember, we implemented screening protocols at virtually every healthcare facility coming in. And for many healthcare providers, our staff was tested frequently to assure that they didn't end up with COVID, even if they didn't have symptoms. So again, those are just some things that came to mind as I prepared for this about what we did learn and the challenges we faced during the pandemic as it pertained to care transitions and communication between and among care providers. So the top 10 takeaways, and the first one should be obvious. We really should be focused on safety first. If there are shortcuts that people are taking for efficiency, or because they have barriers to being successful following policies, and so they're taking shortcuts, we should identify that immediately. We should rectify those problems, and we should continuously train on safety protocols to prevent the transmission of illness, to assure that we are communicating a patient's communicable disease status across care providers, and that they're able to protect themselves. We can say for sure that care transitions are risk points in patient care. I consider them the weak links. They are the places where we are most likely to not communicate appropriate information, and as a result can create health and safety issues for our patients. During a care transition, we should focus on and be very intentional about what are the key areas relevant to the patient, and we should communicate that information. We shouldn't bury it in an EMR that's 100 pages long and expect the oncoming care provider to locate it. We should have a process where that is communicated. We can use a standardized care transition form, and as I said, that is best practice in most organizations, often developed as a collaboration between healthcare providers. But we also should require a one-on-one verbal communication that takes into consideration all the important aspects of a patient's care. As you should have seen from some of the case studies, we should not be relying on memory. We should document things that are going to be critical, and we should be able to identify that at the time that the care or the issue is arising, so that you don't find the huge gaps in the rearview mirror when you're looking at the chart 2 years later. In order to be most effective in doing that, we should document as soon as possible after providing care or doing a care transition, making sure to document the communication between the providers. I mentioned earlier, we should focus on what the next caregiver needs to know. What do you think is important about that patient? It requires you to really stop and think about that patient, not about the number of patients you have, but only that patient at that point in time, so that you can be very intentional about the information you're communicating. Adherence to policies and procedures, particularly those designed for safety, I talked about at the top by saying safety first. And I will say the pressure points during the pandemic demonstrate that this is even more important in a crisis. Where policies and procedures are shortcutted, not followed, it can create problems. And as I said, I did several investigations of outbreaks that demonstrated that policies and procedures were not being followed, and that contributed to the outbreak. I also encourage communication between care providers at all levels of care, and that includes between the physicians and the allied health and nurses and therapies, but it also includes with the patient and patient family members. And again, with the waivers, the communication with patient family members certainly was reduced substantially, and they didn't have the ability to intercede and help their family members. So that was a critical issue during the pandemic, and I think much of that is resolved with the opening up of visitation in most places. And then lastly, taking time to think and breathe. Really, everything you do impacts a patient. And so because of the importance of what you do, having the opportunity to really focus on a particular patient and that patient's issues and experiences and any care challenges you've had at the time of a transition will again improve the quality of the communication at that time. So here I've provided, this is my last slide, and it's really more just for you. This is the resources that I thought might be helpful on the topic. They are all NIH publications, but I thought they were a very interesting read and helpful on this topic. I did not include a citation or a link to the COVID-19 emergency declaration blanket waivers, which I referenced. But as I said, if you type that in to a Google search, you'll be able to find that. And lastly, you'll find on my last page my contact information. As I said, if you have questions, we won't have the opportunity to take them here on this audio recording, but you have the ability to reach out to me, and I welcome hearing from any of you. I hope the information I provided today was helpful, and I look forward to seeing some of you at the conference and speaking to some of you as time passes. Thank you again for listening today, and have a great day.